This is the first time we're doing one of these in the middle of the day for us, but for Dr. Balédent, he's out in Amiens, France. So this is actually closer to evening time for him. So first of all, I just want to thank Dr. Balédent for joining us. And I want to also thank people who have donated to this program in the past. It's been really, really helpful to keep this going. I'm glad to hear that it's been helpful for all of you as well. So if anyone's able to give a gift, every little bit helps to keep this up and running. I also want to start with a bit of a disclaimer, which I talked about before I started this recording. Dr. Balédent is a PhD and he does a lot of work in research specifically. So a lot of the questions are going to be specific to research more so than to clinical medical questions. But if really good medical questions come up that Dr. Balédent can't answer in more of a theoretical sense, then I'm going to save them personally and we're going to use them for the next Q&A session that we have with some of our other doctors. But with that said, I actually want to give a second for Dr. Balédent to introduce himself and maybe explain why you're interested in CSF flow and how you got started in all this. And then I'm going to pause and Dr. Balédent's going to give a presentation before we get started. So with that, I'm going to be quiet and go away, and the floor is yours. Thank you.
Okay. So thank you for this introduction. I am yes, Olivier Balédent, and I am working in the University Hospital of Amiens. It is in the north of France. It's just between Lille town and Paris, of course, and we are only at 1 hour by train to Paris. So yes, I'm not a medical doctor, so I'm just a researcher, and my background is computer engineer. So 20 years ago, I was invited in this hospital to finish my Master of Science. The question the professor gave me was, can you develop some software to extract some quantitative information of the CSF flowing in the brain? And I started to develop my own software and also to learn how MRI is working and also how the brain is working. But in this fact, the brain is very difficult to understand. And I didn't finish to understand how the CSF and blood flow circulate. So I am very happy to be invited by this prestigious and so important association and foundation in the field of the CSF in the world. So thank you very much. I'm a little bit stressed to give a talk to you, but I will try to do my best. So I just start by this slide because I want just to focus on this liquid within the center of the brain, but also around the brain and finally around the spine. And this CSF, if you look at the literature, have many functions, in fact. The first one I learned was that it protects the brain against a big shock you can have in your life. Another very important point is that this CSF is used as a washing machine to clean the brain during the night and to extract all the bad protein built by the brain. But also another important point of this liquid is that this liquid have to maintain the pressure of the system. He is playing in the system with another very important liquid, the blood. And the blood is divided in two parts, the arterial flow and also the venous flow. But I was very interesting to know that, in fact, it is the veins, the most important volume in the cranial system. It is the most important volume, but in fact, if you check the literature, you will also see that it is not the main interest, in fact, in the research or in the clinician. And an old neurosurgeon who was a chief when I started gave me an advice. He said, it is a Professor Legard, very important person in my hospital. He's retired now, and I give him an hello. So he said to me, Olivier, be careful, the veins is bullshit. Don't worry about the veins. I don't want to make surgery of veins. So CSF have to maintain the pressure, and sometimes it is not working very well. As you know, we have different pathology of the pressure, and the hydrocephalus, the Chiari, and its Syringomyelia association. If we go back now to Icp, intracranial pressure as also is very, very important, because if we are living, it's because we have a good intracranial pressure, because in fact, the brain needs oxygen to work, but oxygen to pass from the blood to the tissue need a special equation of the pressure of the blood and the pressure of the brain and pressure of CSF, in fact. And it is the adequation between the two systems that provide a good perfusion of the oxygen inside our tissue. If we are looking at a very simple thing about the cranium, so the cranium is a rigid box, and you put inside venous blood, arterial blood, the tissue, and the CSF. And all this liquid, incompressible liquid, have to be in good adequation to maintain a good pressure of the system. But if a mass, a tumor, or something increases inside the box, the system needs to push out things. And what we can push, not arterial flow, in fact, venous flow, main compliance of the system, or the CSF. So until few months, sometimes few years, you won't have problem, because you have a compensate system mechanism inside your head. But at the end, you can decompensate, and your ICP will increase. So it is very important to maintain this volume inside the system. This is, in fact, a static point. Everything was static, but it's not the reality, in fact, because we have arterial inflow, and this arterial inflow is not a constant flow, and the venous outflow need to compensate this change. If I take this example of an arterial inflow constant, in fact, it's not the case, but you can imagine that we have an input, a constant input during the cardiac cycle, and this input associated with a constant output, in fact, you don't have change in the volume. You put 1 milliliter, 1 milliliter go outside. So no change of the volume of the system. But the reality, we have a systole and diastole. So we have change during the cardiac cycle. The flow is going quickly, but is going quickly by the arterial inflow, but not by the, is not going so quickly by the veins, just because the blood is viscose, an important viscosity, and it needs time to go from the input to the output. So during this time, the brain, in fact, pulsate inside the cranium. So if you increase the volume, the pressure increases. And a well-known curve of Icp is composite, in fact, in 3 P1, P2, P3 bump. So we need something to avoid a big increase during the cardiac cycle of the Icp. We need something, and what is it? The response. In fact, the response is the CSF. The CSF is like water, in fact. It's can quickly go outside the cranium, and where? Inside the spinal canal. Because inside the spinal canal, you have a little compliance who can increase a little bit the volume, and that can compensate, in fact, the increase of the brain during the systoling period. The CSF go down, and when the blood at the end of the cardiac cycle is outside the system, the blood decrease, the volume decrease, and the CSF by the pressure go up. So you have CSF playing like that during the cardiac cycle to compensate the system. We have a very fabulous machine, in fact, to investigate this system. And this fantastic machine is an MRI. So we have MRI in Amiens, like MRI exists everywhere in the world. And with this system, for many years, we know that we can explore the brain. We can make different kind of images. We can see the CSF in the ventricle increased. We can see the cavity inside the spine. We can see, in fact, different static information. But at the end of the 1980s, they developed, Feinberg, in fact, and others, but develop a new sequence. And the sequence now can give us a new information. And this new information is that we can see the system moving, in fact. We can see how the exchange of the different fluids appear during the cardiac cycle. And it is what we will try to present, what I will try to present to you. So if you put somebody inside the machine without any injection, we don't need injection. Just like that, you put somebody inside the machine and just control the cardiac frequency of the guy, and you can get the different information of the system moving inside the cranium. We have 3 liquid, the arterial inflow. You can see a quick increase during the systole, increasing the brain, pushing the CSF through the spinal canal to maintain the pressure. And at the end of the cardiac cycle, we have in blue the blood going through the internal jugular veins. So with this system, we can put a slice at this level, for example, and we can see different little circle inside the images. In fact, it's black, it's white, and it represents just the different flow moving inside the veins or inside the arterial. So we developed a software to extract from the images. It's nice to see the images, but it's better for us to have an information, a quantitative information, how the arterial flow during the cardiac cycle. So we can get this information from the arterial flow, and also we can get this information from the internal jugular. So arterial flow, jugular flow. Arterial flow is very easy. In fact, you have two main arteries going to the brain, the internal carotid arteries and the vertebral arteries. So two on the right, two on the left, only 4 tubes to put the blood inside the cranium. For the outflow, it's more complex. You have the two main internal jugular veins, but also you have many little veins that it is not easy to investigate. So for that, we just measure the internal inflow, the big one, and we compensate. We try to know how much blood pass through the little veins just by very simple hypothesis. It is all the blood going inside the brain will go outside at the end. So if we measure the input, we know the outflow, and we can extract from this information a special a factor that give us an information how many blood was outside by the jugular veins. We can also, with no problem, control how much blood input inside the cranium. So we are just at another level now. We are inside the cranium, and we cut the internal carotid here, the two white one, and also the basilar artery addition of the two vertebrals. And on the back, we can see what happened inside the sinuses, the big vessel, it's not vessel, but the big tube that drain the cerebral veins, the blood. So we can also do that on the aqueduct. In fact, you can see here a very thin tube, and the white is a CSF moving up, down, up, down, up, down inside the aqueduct. We can change the slice and go to around the system to see here the CSF white, black, moving up, moving down during the cardiac cycle from the different Pontin system here. And also we can go inside the spinal canal at this level, for example. And at this level, we are happy to see in white, black, around the spine in the middle, white, black, the CSF moving up, moving down. And we can see, but also we can measure during the cardiac cycle, we can measure the velocity, and also from the velocity and the area, we can get the information now of the volume. What we see here is in fact the volume of the CSF moving up, moving down, moving up, moving down, and in fact in response of the arterial and venous conversation, in fact, inside the cranium. So CSF is in fact, when we see that, we see what's happened in terms of volume change inside the cranium, volume change of the blood. and we can measure and extract some special information. So after I've developed the software and also put a protocol inside the MRI, we apply that in many friends. My parents, my sister, my brother, my cousin, a lot of my family, in fact, and a lot of people inside the residents also and the clinical doctors go inside the system because they don't need injection. And in few minutes, in fact, we can have an information of all the CSF and arterial and venous blood flow moving in the system. And we get this information, and we were very happy to know that, in fact, in healthy population, there is no lot of change. So we can take this information as a reference to go to see what's happened in pathology. And in pathology, the first one was as Bradley, Professor Bradley was the first one who said, oh, you have a flow void inside the aqueduct, and this is a sign of normal pressure hydrocephalus. And if you put a shunt in this guy, maybe he will have a lot of chance to improve his problem. So I go on this way, and in hydrocephalus patient, we study the different value we can have with hydrocephalus patient. And for example, this is just an example. In fact, this one, big ventricles, but normal value in comparisons of our normal references. And this other one, we can see that the CSF increase a lot, in fact, everywhere, inside the ventricle, but also inside the spinal canal. So with this technique, with few minutes, we can have an information of how the brain changes pressure inside the system. And this information, this morphological information, in fact, don't give us this kind of information. So it is for this reason, it could be very important to also assess this information. Also, it's new, okay, so it need a little post-processing, and we need to have reference value. But I'm sure that if we continue to study, we will have addition, complementary information that we can combine with the morphology, with the clinic of the patient, and that will improve a lot the diagnosis and the outcome of the patient. So this is just another example. What we have to see is that, in fact, the black represent with this kind of machine represents the arterial. And I was very interesting because I don't have jugular flow. In fact, I don't have white. Normally I exist white for the veins, and there is nothing. Oh, everything is in the back. And if we go back, in fact, to the angiography, the morphology, we can see, in fact, that the sinuses stopped, and we don't have too nice jugular flow. And if we see on another images, in fact, missing the internal jugular flow, and we have a lot of, in fact, peripheral veins who are present without the important internal jugular flow. So I was very interested by this thing, and with friends, we decided to study the veins, especially the veins. And what we found was that in normal population, in fact, you can have different kind of subject. All these persons are normal. You can have two important sinus. You can have only one big sinus with a very thin one in the other side, or you can have this kind of subject. This subject is healthy subject, and what? he don't have a jugular veins on the right, but you can see here a big one. In fact, the jugular veins don't go like all the physiological things I've seen in the MRI, but up it finish and it start and go completely on the back of the system. So the veins are very difficult to investigate, in fact. So then after, I also found some special subject, in fact, could be LC, but it was strange because the cerebellum, in fact, go inside the, and you know very well this problem. It's called Chiari malformation, and it's strange because in lot of LC subject, in fact, we can see also a different position of the cerebellum. Sometimes it's at the limit, sometimes it's distant, sometimes you have a big cistern with CSF, sometimes there is an empty cistern. So very, very different morphology at this level of the cranium. If you go and have a look to this paper, in fact, there is many paper, but I just take this one because he call it Monroe-Kelly 2.0, and I was interested by the title. And he will also speak about and explain different things about what's happened and how the venous drainage is important, in fact, in the system. So the system is under pressure, a little under pressure, and need to flush the CSF during each cardiac cycle. So at the foramen magnum, we need free space to flush the CSF. And it is, in fact, a little bit the problem of what happened in Chiari malformation. So Chiari malformation, if you need to know if you have a Chiari or not, in fact, simple. If you check the literature, some people say, okay, you have to measure the distance of how much the cerebellum go inside the spinal canal. It's just morphologic. You take different measurement and you can have an information of the severity or the classification of this malformation. So many of Chiari malformation, in fact, are often asymptomatic, but part are not asymptomatic, and in fact have big clinical impact as you know, as headache, visual symptoms, and so on and so on. So how makes the difference between asymptomatic and between symptomatic, and maybe try to improve the patient? So now we know that it is important for the CSF to flush during the cardiac cycle, to decrease the pressure during the increase of the brain during the systole. So we know also that with MRI now it's possible to check this quantitative information. So let's go and try to see if we can go around the spine inside the cavity and to measure, can we have access to the different things that different people already publish and point that it could be important to go inside the system. So today, during this afternoon, I quickly checked my my computer, and just take one subject, maybe to illustrate. It's not all the case are not like that, but just to have a look at what we can do and what we are doing, in fact, in Amiens, and how I can work with my neurosurgeon to try to understand this thing. In fact, we can cut the system here, and when I cut the system here, I got this morphological information, and I can see what's happened inside the sinuses. So this is good. There is patent sinuses, the right sinuses, straight sinuses, sagittal one, and right and left. We can see there is a small one, but also I can see what's happened on the quantitative information. I don't show you the curves because it could be boring for you, so I will just try to explain. This is not good for me. When I see that, a white inside black, that means that the velocity is very important, in fact, more important than the normal I've seen. So, okay. And when I go to this one, now I am in another machine. So now in white, you can see what is moving up. So this is arterial flow, internal carotid artery, vertebral one, but I don't see, in fact, black. And I see black at the back. So that means that we are, and if we go back to the morphology, we can see that I don't see very nice jugular flow, but a big little veins on the back. So that means that maybe exists a kind of jugular stenosis. There is restriction of the outflow. So on the Chiari now, I change the parameters and I go with a low velocity to see what's happened. So I will try to just to give you an information. So I am at the cervical level. At the cervical level, around the spine, I have the CSF. This is morphological images, so it's normal. I have a lot of CSF around the spine. Very good. Now, if I check on the quantitative information, what you can see exists a black. The CSF is moving, in fact, is moving down when it's black. Oh, it's white, so it's moving down. So exists at this level, CSF moving up, moving down. So, okay, it's good. We have a compensation of the system. We have a compensation of the system, but in fact, we can also check what's happened at the foramen magnum. And at the foramen magnum, I'm not so happy because I don't see a lot of CSF in the morphological images. I see there is CSF, but if I check also to the quantitative information, when I measure this information, it's very small, around 30% of what's happened at the cervical level. So exists a restriction, in fact, at this level of the CSF to go inside the spinal canal. So it's not normal. We have CSF and we have normal CSF, so missing something. So I think you understood quickly that the missing volume is here. The missing volume, in fact, is the cerebellum. The cerebellum is moving up and down, and it is why we can see, especially at the systolic phase, systolic period, a very important black signal. That means that at this moment, the cerebellum quickly move inside the cranium. And if I check a velocity and change the velocity, and now we can see a very nice, and we can measure the volume change of the cerebellum inside the cranial spinal, and we can see that it's white, it's black, that we have a moving cerebellum inside the Chiari malformation. So it is an information that I can measure and I can give to to the neurosurgeon. So when we discuss together, I have a few. It's a old work. In fact, it's 3-4 years ago. We check the database, and from the database we extract, in fact, 21 patients that the neurosurgeon in whom the neurosurgeon have make a surgery. In fact, the surgery is it's a laminectomy. They increase a little bit the foramen magnum, or the pressure around the foramen magnum, by 2 different surgery. And also, what we done, we make an MRI before and we make an MRI after the surgery. We make an MRI at different level, as we have seen, so we can measure what happened in the aqueduct, what happened at the foramen magnum, what happened in the cervical level, in the blood, and also in the CSF, and also in the cavity when exists a cavity. All this acquisition, it's around 2 minutes per acquisition, 1, 2, 3, 4, 5, 10, around 10 minutes. We can have a complete information of the arterial inflow, venous outflow, and CSF oscillation at the different level of the system. And we can also not only have the images, but also have the information concerning the volume. So I extract from Cyril Capel. Maybe he will present it. He is neurosurgeon in our department, and he will present it better than me, the different information concerning the clinical the clinical before and after the surgery. But all the patients, in fact, were happy to have an improvement after the surgery. But go back to the measurement, to the quantitative. What we have seen, in fact, first things, no change in the CSF moving inside the aqueduct. So the ventricular system is not affected by the malformation. What it was interesting to see, it's that after the surgery, we have seen a very nice improve of the CSF around the spine at the foramen magnum, and also a decrease of the neuroaxis inside the system. Also, we have seen that this surgery make an impact, had an impact on the venous flow, on the cerebral venous flow. So it is also interesting to keep in mind that venous flow maybe can play a role in this subject. In the population, around 12, I think, around 12 patients presented also a cavity inside the spine. And when we check this population with a population without cavity, we see an interesting difference concerning the venous system. In fact, when patients presented cavity, in fact, exists a very we have seen that exist more veins, more little veins, and it's very interesting to see this. This is a facial veins, in fact, very big. In fact, it's a very big vein. So we can imagine that the system increase because the pressure of the arterial inflow is very important, and nothing can stop the pressure of the arterial inflows. So the blood flow increase the system, and the system need to push something. He tried to push what? The veins, but it's blocked. So he pushed the veins inside the very little thin tube, but it's more difficult. So he need help. And what help he can push, maybe can make a movement of the system to have volume, to give compliance of the cranium during this this systolic increase. So we have seen that in 10 minutes, in fact, without injection, with an MRI, you can have an overview of the different liquid moving inside the system. And also, it's normal, it's not a very, but we have seen that CSF, in fact, have difficulties to go from the cranium to the spinal canal because the space was limited by the Chiari. And also that the Chiari can impact, in fact, the cerebral blood flow. But the other question is also, maybe also the veins can impact the Chiari. So to conclude, what I have seen is that the arterial blood flow need something, need first the veins, because all the blood will go outside in the veins system, but it is not immediate. In fact, it needs time. It needs the time of the cardiac cycle. During this little period of 1 second, you need something else. You need the CSF going down, but you need the CSF going down by the foramen magnum. And if you put something inside the foramen magnum, you decrease the area, so you increase the pressure, and the pressure will impact, in fact, the different tissue inside the system. So it's this pulsatility mechanism, I think, is now at the beginning, 20 years ago, a lot of people were very smiling. In fact, when you say, okay, I measure CSF, I measure different things, it was okay, nobody was very interesting. I think 20 years after the beginning of this research, I'm happy to see that many papers, in fact, and many friends work also on this field. And in US, in Sweden, in fact, everywhere, we have a lot of people working in this field. And because MRI is an amazing tool, and also increases power years after years, I'm happy to say that in the next 20 years, I'm sure that we will have a very nice investigation of the system, and we will understand the system, because we can now have volume acquisition. But important point, all the studies don't take into account the gravity. So I would like to have a vertical MRI. So people who have vertical MRI, please have a look at this system. It's a very important system, and you will be very happy to see that the system works differently. I think we will revisit the anatomy when we will check the system in the vertical position. And also bracing, missing the bracing, because we change also the pressure around the spinal canal when we with the bracing. And now we have a new real time, and new information will give us very nice result in the next year. So I put only my name, my first name in the first slide, but in fact there is many people who are working with me, the radiologist, in fact, the neurosurgeon, and also the technician who are playing with me with the MRI, and also the student and my old friends, the engineers that I'm check and say thank you very much for everything and to help me to investigate these fantastic flow measurements. So thank you. Thank you to listen.
Thank you so much, Dr. Balédent. That was really, really awesome. A lot of people are asking really interesting questions. And first of all, they did want to tell you that the work you're doing is really amazing. And while they hope it doesn't take 20 years, this stuff, it's amazing how ahead of the clinical imaging that this all is. But we do have a couple of questions if you have some time to go through them.
Yes, of course. Thank you.
Awesome. Okay, so this came in before the presentation started, but it has to do with blood pressure. So I guess if you can just quickly explain what happens to the CSF flow when blood pressure is low, maybe with the cranial vessels in a normal patient versus a patient with Chiari. Is that something that's different in a Chiari patient with a low blood pressure?
So, yes, what's happened when we have a low pressure in the system? In fact, arterial pressure is very different than the CSF pressure. It's more than 10 times around. I don't want to say something wrong, but you have to know that arterial pressure is very different than all the other pressure. And when you have low pressure, you continue to have pressure higher than all the pressure inside the brain. So, in fact, I don't have really the answer, because I think that what also is important is not only the mean pressure. It's like ICP, in fact. We don't have to take into account only the mean pressure, but in my investigation, what is very important is the change of pressure during the cardiac cycle, the amplitude change of the pressure or amplitude change of ICP. So it's difficult for me to answer the question, because you can have a low pressure, but maybe with high amplitude. So, and also what's happened in terms of change of volume, because maybe with low pressure, you can have a big flow and increase a lot your system. And if you increase a lot, maybe you can also have a problem with the CSF and with the ICP. But it's a very nice question, in fact, and not now because I don't have time in front of you, but at the end, I will check and I will ask my medical doctor to know if you can have a low arterial pressure associated with a high ICP pressure.
Okay.
So I don't know if my answer is very good for you, but maybe you have to go back in 20 years. I will work on this question, and I am sure I will have answers better than today.
That's fine. So you talked a little bit about this, but as far as the anatomy is concerned in the brain and the cranium, there was a question about the cavum, septum pellucidum, and really other things like sinuses and stuff. And you talked a little bit about it, but I guess it's just more about how it affects this pressure in the CSF flow. Is there any way to know what those little cavities are that might be affecting the pressure in the brain? And without this super advanced technology, how else is that something that you guys get clues to look into, I guess? I don't know if I'm making sense. in asking this. There are a bunch of little areas where fluid can drain. So how do you know, without getting these phase contrast MRIs, where to look? I guess is the question.
You ask. I want to be sure that I well understood the question. You ask me without PC-MRI, without this technique, how we can we can see what.
Is there a way?
I think if you don't use quantitative information, you can get the answer. You can't have a good investigation. You can see, but because it's a very complex, you can see the morphology give you information, but it can't give you quantitative measurement of the flow. But this technique, in fact, is present in all the MRI. It's not a very new, or it's a very old one. It's all the MRI system have this sequence. It's a very old sequence.
Okay. A follow-up to that, there is a question if your protocol is being shared in other hospitals, or if right now is it just at your institution?
No. The protocol is yes. I share the protocol. Everybody asks me. I give the protocol. I give the software, and I can also come to. I am invited in many hospitals to install the protocol, to teach how to use the software, and so no, it's open and it's free. So just a few times maybe you need to, but no, it's a very, and it's not only in my I know many people in fact in US you have Noam Alperin, who is my friend, and who is working and in fact in the same thing. So you can ask him. He's a very good guy, very nice and very clever. Also you have Bryn Martin, also working in US, and many other in Sweden. We have a nice tool in Humea with Malm, for example. I can give you many people. So
awesome. That's great. I can actually link to Dr. Alperin and Dr. Martin's professional pages too for everyone watching. There's actually another radiologist who does research on this, and he has a couple of questions, so I'm gonna do my best to ask them. So one of them, in their CSF flow studies, they had found there was a distinct difference in flow characteristics in normal subjects and in patients with Chiari 1 at around age 12. Is that something that you've seen, or is that specific to his patient population?
In Chiari, in fact, there is sometimes some patients with different flow than the normal population, and it is for this reason it is interesting. And what I tried to show is that in Chiari, sometime in few patients, and I think maybe it could be the most important things to show, it is that you have a movement of the spine and also of the cerebellum, of the amygdala inside the spine. So that you have this information, and you don't have that in normal subject, in fact. So you can have also an increase of the CSF at the cervical level, because the pump is moving too much. And also what I point is that you can also see, in fact, impact of the arterial and venous flow between the two populations, between the normal and the Chiari with a clinical symptom.
Dr. Quigley, are you on?
Yeah, yes, thank you. No, what I was getting at in the studies that I did at Wisconsin a few years ago, I say it's a small population of normal subjects, but in normal subjects, you see a change in the characteristics of CSF flow, in the foramen magnum or about the, C2 level. And around age 12, there's a difference. You get what I can maybe post the reference on this, so maybe Caitlin can send it out to everybody. But so you see changes in normal subjects. There's a pediatric characteristic flow, and you would say an adult flow
Yes.
also. But then with Chiari 1 patients who are symptomatic, I also saw different changes in flow abnormality. So this is kind of turned out to be kind of important. And one patient who was 12 years old, the question was, after a couple of decompressions, if her flow had returned to normal, that is to say, her pressure returned to normal. And in fact, it had. But if I hadn't known that she was 12 years old, and thought that she was still an adult, there would have been some question, because she exhibited a pediatric type of flow as opposed to an adult one. So it was that made me go, looking into this. So it was kind of I was just wondering, like I say, it's only been a handful of patients. Well, I shouldn't say that. It's more like about 30 or 40 Chiari patients that I've seen this in, as opposed to maybe about a dozen or 15 normal subjects. So I was wondering if I'm the only one who's seen this, or if it's if you've seen it also.
Well, what I understood of your talk is exists difference between children and adults, and yes, I found the same. I found that exists a difference between, for example, at 2 years, 3 years, pediatric, in fact, change during time, and it's more difficult to have an information, because first, I think we need to have a reference information concerning the different age. We start to do it, but it's also difficult to have a control children in France. It's ethical. It's difficult. It's possible, but it's difficult. But I think very good point that we have first to know how it changed during the growing children, and with this information we can see what's happened in Chiari. But even without this reference values, sometimes if it's blocked, it's blocked, and we don't need to have a reference value, because we see and we measure the impact, and the result is it's very, very different than normal. So it is yes, I think it's important to have a reference value at different age for children, and also, in fact, for adults. Young adults are very different than adults, old adults. So each age have different reference value, but in fact stay inside a physiological range. And when you have a very important patient, the value is 20. It could be 3, 4, 5 times more than the normal that we know.
Okay. There was a question that I had actually had, but there was another question that had come in about it. Have you done work on measuring CSF flow in things like Parkinson's or Alzheimer's patients, as far as flow volumes? And I know I actually think you did something about this in relation to cognitive deficits. So I don't know if there's anything you can speak to those two things.
Yes. So this is very different than the Chiari, but yes, of course, yeah, we were very interesting to study the Alzheimer's disease, in fact, because it's a very important disease, and we don't know really what the physiopathology of this. So a few years ago, we studied the population, and in fact, what we found is that in Alzheimer's disease, the flow, in fact, is like normal. The CSF flow is like normal and decrease a little bit. So we have a decrease of the oscillation in Alzheimer's disease. But what we found is also that in Alzheimer's disease, maybe arterial inflow can be impacted and can increase the amplitude, or we can have an impact of arterial inflow that could be could be important in this disease. More arterial inflow, in fact, in Alzheimer's disease, and it is also some good result to compare and to try to make a diagnosis between normal pressure hydrocephalus or active hydrocephalus, that sometimes the symptom in the aging people are difficult to separate Alzheimer than other neurodegenerative disease. And I'm also think that by investigate the flows, we can also help to select the good patients, because if you check the literature, you will see that a lot of people think that in all the Alzheimer's disease, around 10% of the patient, in fact, don't have Alzheimer's disease, but can have also a CSF disorder that can be found with a PC-MRI. And if we can just take 5%, not 10, but 5% of all the Alzheimer's disease who are not real Alzheimer's disease, I think we can increase the life of diseased patients. And when it is a CSF disorder, it is in fact the only pathology, the only dementia that you can treat by put a shunt. And with a colleague in Cambridge University in UK and with other hospitals in France, we will combine the ICP measurement and infusion test, in fact, with the gold standard to select the patient to go to shunt with MRI. So we are building a new population, new investigation population of CSF disorder, where the patient will have both MRI and infusion test to check not only the morphology, not only the flow, but also the pressure. And with artificial intelligence, with a colleague of mathematician, I think we will have a new diagnosis in the future to well selected the patient in the neurodegenerative disorders.
That would be amazing. There's a question: does this lend credibility to the idea that CC-SVI is a real phenomenon, quote unquote? So chronic cerebrospinal, yeah, chronic cerebrospinal venous insufficiency.
Oh yes.
So. Yes. Okay.
Yes, sorry. Yes, I understood. Well, so the question about CCSCI, it was.
So do these results necessarily lend credibility to the idea that it's a true phenomenon of prolonged insufficiency? Not necessarily related to MS, they're saying. I'm not sure.
MS, multiple sclerosis. Also, it is a question about MS and CC. It's a few years ago. In fact, I think 10 years ago around, there is a big work from Italian team who associate MS and internal jugular veins stenosis or reduced veins. In fact, at this same time, we developed with a colleague, with a professor in neurology now in Brussels, Soraya El-Sankari. She worked with me during a PhD, and we studied, and also with a friend of Brussels team, we follow MS population and also LC subject. And in fact, at the end, we didn't find any differences between the reduced flow found in the MS population in comparison with the LC population. What I quickly, in fact, it was quickly, but what I put quickly during the presentation today was that, in fact, in LC subject, we can have sometimes no jugular flow in one, big in the left, or nothing, and big jugular flow on the right. It's very heterogeneous anatomy, in fact, in LC population. Arterial inflow is very strict. It's very up. It's right, left, big one in the internal carotid, small one in the vertebral. You have 4 all time. You have 4. Sometimes it's a small vertebral, but in normal population, it's all times the same. You know where are they, and you will find it. For the veins, I'm sorry, but the first time I put myself inside the MRI, when I go outside, I found no jugular veins on the right side, and I was very sorry. I said, "Oh, I'm missing a big jugular veins. I'm not like in the book." But in fact, no. All friends also have, a lot of friends have different anatomy of the jugular inflow. So it is the reason maybe why the people, when they put the MS population inside the MRI or with Doppler, and they say, "Oh, missing something." Yes, but if you compare with LC subject, you will maybe find the same thing. It is what we found 10 years ago. So I didn't continue to work on this field.
So there was a question about, you touched on this with the breathing. So did you have, when you look into stuff like that, do you have the patients breathe like they always breathe? Do you have them breathe in a specific way, like holding their breath or something? And does that affect the CSF flow, I guess?
Yes, concerning the breathing, I can recommend. I'm sorry, in fact, I was late and I prepared that this afternoon, and I'm missing, but it's like that. But I can recommend to check the literature, and a very good team in Australia from Lynn Bilston. You can check that, publish a very nice paper. I didn't read it everything, but the first, I found it yesterday. So with a new technique, with a new real-time technique, her group check the CSF during breathing, and you can see that breathing impact, in fact, the system. Not so much that many other papers point. They said, it's bracing the main system that it is a system which move the CSF. In fact, cardiac is not important. It's bracing the most important thing. I'm completely not agree with that because if it is true, in fact, forgot everything you learn, you listen today, and because all the research are not useful if it is bracing the most important thing. In fact, it is the main force. If only if I think if you make a very important brace, but if you are a normal person and you are bracing normally like me, but I'm speaking so I brace a lot, but if you have a normal bracing, you have a slow change of the flows, but the main change is during the cardiac cycle is from the cardiac.
Okay.
It is my thinking. Maybe I'm wrong, so but check the literature. Lynn Bilston, and also for Chiari, all the papers from Badelia, from US Badelia, Rafik Badelia, who published. I read this paper when I was a student, so it's old papers, and Rafik worked first, I think, on this problematic about Chiari and also bracing. So Rafik Badelia from Harvard University.
Okay. So have you done any research specifically with how a Valsalva maneuver would affect all of this? Can you talk about that a little bit?
Yes, in fact I didn't. I was inside the MRI and I did it. Yes, okay. You increase the system and you will see. We never published that, and I tried just a few papers of that. I also tried on myself to block the jugular flow, and it's very interesting because you block you are a little bit red, but nobody see because you are inside the MRI. So you block a little bit your jugular flow, and you see the increase of the flow inside the little veins, and also the change inside the CSF around the spine. And the question, in fact, is good. And maybe like I talked about infusion test. In fact, today, this very interesting investigation is I stress the system and I see how the response of the system is when I stress the system. So we can imagine that something like that you can put somebody inside the MRI, you check normal bracing, and you can ask him to change the bracing. And you will see how the system will answer. If it is a good answer, that means that the system is working correctly when you increase the pressure. If you have problem, maybe that means that missing something in the system. Like also, I think about talking. I think about a very important thing also is the frequency of the cardiac cycle. The frequency of the cardiac cycle could be also a very interesting thing to change, to check what happened, because we are talking about the veins, how the blood from the cranium go outside the system, from the veins. If you have a time to flush the blood, the system will work correctly. But if you increase, if you run, for example, some people have problem after running, for example, because you increase your beating, you decrease the time for the blood to go outside. So maybe your system works normally in normal condition, but if you increase, if you increase your cardiac cycle, maybe the system, in fact, won't be able to work normally, just because you change the system and the system just have a reduce of the venous outflow. So during this time, the pressure increases.
That's really interesting. And there are a lot of applications, like someone had just said, about postural issues and with different cardiac things. But I don't want to take up too much of your time, so I'm going to squeeze in one last question, and it's really more of a forward-thinking question. So based on some of the research that you've done, what do you think is the future for medical imaging that can help get to the root of problems with CSF flow? Like, what do you see as being in the clinic that you work with neurosurgeons every single day and you just know what the answers are? What do you think is going to happen in the future?
I'm a dreamer, so maybe I don't know, Bill Gates, for example, will call me tonight and will say, okay, Olivier, I give you money, and what do you want? What I want first is an MRI that we can change. First, a vertical MRI. If you have a vertical MRI, maybe you will discover a new anatomy and a new physiology of the system. And I think it's very important because we will take into account the gravity. And it's also important to see that, because you are talking about the future, but about the future, people want to go in Mars. They want to go in the space, and in the space you don't have gravity. So it is very important to study the gravity. And if you talk with Noah Malperin, who is working also with NASA, he will tell you that exists an impact after a long time in space when the astronauts go back. So they have problem from the pressure. We don't know really if the Vance pressure, the ICP pressure, but exists a problem. So we need to study the system during change of gravity. Second one, this is real time. We need to have not only one cardiac cycle. What I show you is only one cardiac cycle. We need to have real-time acquisition with a very, very nice accuracy of the measurement. Another thing is also to see the CSF. A very nice new field appeared few years, and the name is glymphatic, G lymphatic. It's a very new field because we change the level of observation. Now we want to see the CSF not only in a big movement, but also what happens of the CSF around the arteries, around the veins. What is the communication between the CSF and the veins? How the CSF take away the toxin from the brain? You're talking about Alzheimer's disease. There's a lot of things to do in this field. And also in this field, when we're talking about the field in MRI, we can also maybe think about increasing the field. If we increase the field, we are 1 Tesla. The first MRI was 0.2 Tesla. 1 Tesla, 1.5. Now we are 3 Tesla. Now we are ask our region and my President Macron, s'il vous plaît, please, President, give me money to buy a 7 Tesla. We need that with my friend from Lille department to have this new, because we will see smaller pixel. In Paris, they built 11 Tesla. So we will see small, very, very small things. and molecular imaging, I think, will be the future. And the very, very good future will be also open MRI, because we are the eye of the hand of the neurosurgeon sometimes, but we don't see in the same time what he's doing with his hand. So maybe we can imagine that working with a neurosurgeon directly inside the theater under MRI investigation to help his hand to select the good way to improve the patient. It is a dream, and maybe if people heard me and help us, we will go back, maybe not in 20 years, but maybe just in 5 years with a very good news.
Yeah, that was amazing. And I think we have a couple of connections. Dorothy was mumbling to herself next to me. So we would like to help make some of this possible. But with that, I just want to thank you so much for this. This was a great presentation, and it was really interesting. And I know everyone, at least that I saw, loved it. And then, oh, Dr. Quigley added something. I'd add that using contrast agent works well in measuring CSF velocities, much lower levels of noise. Probably hard to get insurance to pay for it, but that's definitely something that we have to work on. But so thank you so much, Dr. Balédent, and thanks everyone for coming. And Susan, thanks you for being a dreamer. So thank you so much. And if anyone wants to get in touch with you, I can put your university page on this video when it's ready. Merci. Yes. Thank you.
Merci beaucoup pour votre présentation. Et puis, je vois que vous avez fait de gros progrès en français. Et j'espère qu'on aura l'occasion d'en rediscuter. Donc, thank you very much for everybody. I'm sorry for my little French English, but I hope that you, and if you, it's very open to send me a message, and we can have a talk together. If you have questions, I will be very happy to try to answer. So bye bye.
Thanks everyone. Thank you. Au revoir.